Hi, so how many of you are just itching to do stage 4 surgery? Great, that's wonderful. I know that there are many who are already doing, so I'm not asking them to raise their hand. So let's go and see like what is the big issue. So the first thing to remember is that the retinal detachments, stage 4 and beyond, they can be various types. The highly common is the tractional detachment. So these are not reg detachments, so they don't need any tamponade or laser to a break. So you don't need to do a retinopexy for a break. Few of them would have an exudative component, and we should know how to manage that. More recently, we have started recognizing that although regmatogenous detachment in ROP has been described in older children, but as you saw Dr. Dogra's case, sometimes they can come back with combined RD even in the acute phase, and this has not been much talked about in the literature. Almost all of them are bilateral, very rarely we have unilateral. It will start within 2 to 3 months of age. Of course, if it's aggressive, zone 1, hybrid, it will start earlier, and it can have various configurations. The configuration mostly decided by whether there's a persistent fetal vasculature stalk on the disc and which is acting as a scaffold and closing the funnel. So differential diagnosis should be kept in mind. We've had patients where actually it's a viral retinitis, or it's a toxocara, or there's a fungal candida abscess, or a fungal ball inside, which has been mistaken as a ROP. So remember, it's a progressive disease, unlike your tractional detachments of diabetic retinopathy, which can take ages to become worse. The vision and the potential for vision progressively decline day by day. So these are emergency cases in most situations. So there are various approaches to the surgery, and we can have various things, but most important, which I've highlighted in yellow, is when not to operate. So there are patients who come with sort of stage 4, which is already in the psychiatrical stage, it's already silent. And how you detect that is that, number one, the media is clear. There is no vitreous haze when it goes into psychiatrical stage. And we have shown with our studies that this vitreous has actually a lot of inflammatory mediators when it is active. So if you don't see each vessel clearly, then you can think that this is going to worsen. The other is, of course, the pupil dilates very well and very easily. But of course, the configuration of retina also you see whether the vessels are silent, and then in those cases, we don't do any surgery. So belt buckle, this case Dr. Gopal operated many years back after I had done laser in a one-eyed child. He's now a university postgraduate. You can see that the retina is dragged towards one side, but there was no persistent fetal vasculature stalk. The funnel was open, and only in the periphery there was some traction. So a belt was put, and after a year it was released. And this boy is using telescopes, magnifiers, and he has decent vision. Notice the disc cupping. Recently he has had raised pressures and he is on timolol controlled. So we need to follow these patients. All these ROP patients, they can develop glaucoma, and we publish glaucoma after ROP surgeries. Now these are tractional detachments, so the funnel was trying to sort of close down, and the patient has come a little late, and we put buckle, belt buckle, and the posterior retina then opens up. So these are cases where there is a peripheral traction, about 4 to 6 clock hours, and the disease has sort of died down, then you can do belt buckles. So I have recently, started doing sclera imbrication in few of the cases where there's a combined tractional and reg RD or a bad tractional RD. I'll show you one of the cases, this case from Dhaka. So normally we would have done a lensectomy, vitrectomy, or a nasal side partial vitrectomy to reduce this disease. You can see it's very active, but we just did a buckle, and that's how the whole thing has improved. So there would be limited indications for some of them. But the most common indication for lens sparing vitrectomy is something like this, where you see the retina is sort of lifting up, and it looks like it's going to be silent. When I saw this patient, I thought, okay, the macula is spared, it's just a little bit of nasal thing, I'll just add some laser and see what happened after a week. Still I was happy. And then 5 days later, see what happened. So that's what I'm trying to say, it's very active, it's aggressive. And you can see there was media haze here all over. We could not see each vessel clearly. So that was an indication that it's going to worsen. Of course, we operated and got good outcome, but if we had operated at this phase, then it would have been much better, and there would not be that much of drag and CME. So this is the time that you should send for surgery if you're not doing yourself. You saw the patient has aggression, you did the laser, and you see that some area is lifting off. This is the time to immediately check the hemogram, give the transfusion. 90% of these babies are anemic at that time. Their hemoglobin is 7, 8, and then refer immediately. And we can do a 20-minute surgery, and everything becomes very good. and there's no traction on the retina, and things become good. So that's the advantage. So there are various forces which we have to cut during surgery. I'm not going to go to all the details. These are technical details. But main thing is we don't want to touch the lens. We don't want to touch the peripheral retina or create a detachment, and we want to remain in this trapezoid area where we can just cut these membranes in the vitreous and get it back. So I hope this video will run. So this is sutureless vitrectomy, where we are just putting a bolster of the 240 band here so that the amount of trocar inside the eye is less. I pull the conjunctiva on the cornea so that I can deposit it back and do a sutureless surgery. We don't need to do, you can use 23, you can use 25. And most important is that when you're putting these cannulas inside, make sure that they are well placed. You can see here this cannula is sort of little loose. And this is what happens during surgery. It can come out and create a choroidal, or it can touch the lens. Or when you're doing fluid exchange, the air will come into the AC and lead to glaucoma later. So this is very important that all the cannulas should be properly placed. I keep this cotton wick in all cases to drain away all the water from there. And so then once you've done this, put the 3 things, and mostly we make the horizontal incisions at 3 and 9 o'clock. So we are not worried about damaging the ciliary vessels because we are quite anterior. This is 1 to 1.5 millimeter from the limbus. And the whole surgery is done with good guard connection of your vessels. And then when you go inside, you need to break all these drag areas. So I'm just going to stop here and go to the next one. So I just wanted to highlight here that if you see that the retina is pulled up, or you see an opacity in the periphery, that means that retina is pulled up there. Then you cannot enter through that area. Then either you have to enter nasally, or you have to sacrifice the lens and enter the lens. So this is the most critical part of surgery in stage 4B ROP. So then, of course, you can have other types of detachments, like a bleb-shaped detachments, which we have described. In these cases, you need to act very fast. You need to give anti-VEGF. Within 24 hours, you need to do the laser of the peripheral retina and get them to the table. So the outcomes of these are sort of moderate, because these are really fulminant cases, and these are cases who've come late. But still, you can get decent outcomes if you follow the triple attack on these eyes. You can also have exudative RDs. So most of these RDs don't need surgery. They look very horrible, but once you give the anti-VEGF and do the laser, they do pretty well. So the most important thing is, if you have done surgery in one eye and not done in the other eye, they will develop transient anisometropia, very severe anisometropia. You can see here both eyes had laser, and the one which had surgery, it went into high myopia, -4, -11 within few months, and the other eye slowly went, and by the time 2 years, they were all same. So this anisometropia is very important for you to do the patching, give that management. So if we operate the eyes, we start the amblyopia therapy right from first week post-op. So this is just to show the joy of seeing somebody who was labeled as going to be blind, the vision rehabilitation, the glasses, the myopic correction or the aphakic correction, and then patient wait. The outcomes of these surgeries should be assessed at 3 and 4 years of age as far as the visual acuity is concerned, not at 6 weeks or 2 months. The retina takes time to go back. It takes time for the vision to develop, but your persistence leads to really good outcomes.